Good morning, ladies and gentlemen. You may perhaps wonder why they choose me on such a high-level meeting. Well, I must confess, I don't feel very much at home between all those smart people on the program. But anyhow, I'll try to show you during my lecture, you don't have to be an anesthesia or a pharmacology professor to use the SmartPilot. In 2010, the journal Anesthesia and Analgesia had the visual drug displays on the cover. You can see the navigator over here and the SmartPilot. In the table of contents, we see Ross Kennedy, the next speaker, and his lecture will be about the navigator from GE, while I will talk about the SmartPilot from Draeger. This does not imply that one is better than the other. Also, we see Tony Jin, and he states in an editorial in that same issue that most subscribers wouldn't read the articles on visual drug displays. He was right, and I was one of the people that didn't read them. Also, in 2010, Joe the plumber had a left inguinal hernia, and I was his anesthesiologist. We start with sufentanil, 50 micrograms, and a few seconds later, Joe says, "Hey, I'm feeling dizzy." Aha, we say, the sufentanil has arrived, and we give a bolus of 100 milligrams of propofol. But nothing really happens. So we give more propofol, but only after 200 milligrams, Joe finally becomes unresponsive. Then we place an LMA, and the next blood pressure is 60/40. Oops. We need some ephedrine. We keep Joe and the surgeon happy with an end-tidal concentration of sevoflurane 2.3%. This is 1.3 Mac. The blood pressure goes up and down during the procedure, and we have to give ephedrine several more times. After 45 minutes, ask the anesthesia resident to give some more sufentanil, but he is not convinced and argues that the blood pressure is low. Anyway, 10 minutes later, the surgery is finished, and after 5 minutes of desperately trying to wash out the sevoflurane, we give up. We put the patient in his bed and we transport him to the recovery room while he's still sleeping. There he opens his eyes 10 minutes later. As an anesthesia resident, I was trained by Jan Hendricks on the mysterious powers of anesthetic gases. Total intravenous anesthesia and target-controlled infusions were really not my cup of tea. Too much hypotension and very unpredictable. Like most anesthesiologists, I think, I choose for my patients the safe path of inhaled anesthesia. Now you may ask, why is that so safe? Well, because realizing it, I had in my OR a visual drug display. And we all have. And we look at it all the time. We have the Mac on our screen. 1.3 Mac gives me, after 15 minutes, a 95% probability that the patient will not hit the surgeon. Now, that is great, but it still doesn't give us information about other drugs we use, like IV hypnotics and opioids. Therefore, we must travel to the mystic land of PKPD, where smart people and supercomputers are working on difficult mathematical models. With these models, they're able to calculate effect site concentrations. That is great, but we use various drugs at the same time, and these drugs work on the same clinical effects. This is called combined drug effects. In order to solve that problem, the smart people discovered response surface models. This is an example of the response surface. These models display the synergy between hypnotics and opioids. The response surface is a three-dimensional graph that gives you an idea about two drugs and one clinical effect. Here you see on the X and Y axis the effect site concentrations of SIVO and remifentanil, and on the Z axis you have the clinical effect. In this example, it is the probability of no response to intubation. Now, different combinations of effect site concentrations can result in the same probability of a certain clinical effect. These are displayed on the response surface as one line, and we call it an isoball. We have the yellow isoball, and it's the representation of all the combinations of effect site concentrations that give a 95% probability of no response to intubation. So we may say then we have an anesthetized patient. Also we have over here the green isoball. On the green isoball are all the different combinations of effect site concentrations that give a 5% probability of the clinical effect. And thus we may speak of an awake patient. The smart people, no, not the smart people, but everyone, we can, if we look from the Z-axis down towards the response surface, we actually see a 2D graph, and this is much easier to handle. On this graph, awaken is nothing more than going from a 95% probability to a 5% probability. We know, and we can see it on the graph, that it is possible to have no response to intubation with a high concentration of sevoflurane alone without any remifentanil. We also know, and we can see it on the other side of the graph, it's not possible to have the same probability with remifentanil alone. However, we still want to be more on the right side of the graph with a relatively higher effect site concentration of remifentanil, which has a slow offset, and with a lower effect site concentration of sevoflurane, which has a slower offset, in order to keep the time for awakening as short as possible. So now we have a 3D graph that was made more easier by a 2D graph, and the smart people made it even more easy. You may say one-dimensional. They invented the noxious stimulus response index. Now, the NSRI represents, for a given combination of effect site concentrations, the probability of response to a certain stimulus. The NSRI is a number going from 100 to 0. If the NSRI is below 20, there is a high probability of tolerating painful stimuli. If the NSRI is above 90, there is a high probability that the patient is awake. Now, whether it's 3D, 2D, or only just a number like the NSRI, we still cannot use it in clinical practice, because for every different combination of drugs and for every different patient, there's a lot of calculations to be made. And this is when a visual drug displays like the SmartPilot can help us. All the different mathematical models are incorporated, and all we have to do is just enter the patient data and the drugs we give. Now let's take a closer look at our SmartPilot. On top we see the patient data. These are entered in the ZIRS and transferred, or we can also enter these directly into the SmartPilot. On the right we have the calculated effect site concentrations. For inhaled anesthetics, these are based on the end-tidal concentrations measured by the ZIRS. For intravenous anesthetics, these are based on calculations either based on the data entered by the anesthesiologist himself on the SmartPilot, or based on data from syringe drivers that are connected to and steered by the ZIRS. It's also important to know, but you already know about this, there is a part for prediction for the next 20 minutes. Next, we have our response surface graph with different isoballs for different clinical endpoints. We have one isobol that says TOS, tolerance of shake and shout, and we have one saying TOL, tolerance of laryngoscopy. The response surfaces and also the endpoints are different for propofol, where we have the endpoints TOS and TOL, and for inhaled anesthetics, where we have the endpoints TOS and MAC. Now, on the response surface, we can see the trajectory of our anesthesia so far. We can also see a part for the future. The orange dot is where we are now. The black dot is where we will be in 10 minutes, and the arrow is where we will be in 15 minutes. Finally, on top, we have the calculated NSRI. The NSRI is also displayed graphically with a part for prediction over time. You heard the word prediction a lot of times already, and that is because prediction is an important feature of visual drug displays. What if I would set the entitled target for desflurane at 8.4%? The yellow predicting curve moves along and I can see where I will go. What if I will give 50 milligrams of propofol? Well, then I see that my NSRI would be below 20 and I would have a high probability of a patient tolerating laryngoscopy. But now let's take it into clinical practice with a little test case. A few weeks ago, Joe the plumber was back on the table, this time with a right inguinal hernia. So we enter his data in the Zeus, and these appear on the screen of the SmartPilot, where we also add his gender, male. We start with a bolus of sufentanil 25 micrograms. Joe immediately reports that he is dizzy. But guided by my visual drug display, I'm planning to wait for the maximal effect site concentration of sufentanil. As you can see, this will be over here. This will allow me to reduce my propofol dose and likely will have less hypotension. Obviously, I will need less propofol here than I will need propofol here. Also, I will be able to intubate at the time of the maximal effect site concentration of sufentanil and not before it. Meanwhile, Joe is actually still awake, and we wait. We wait almost 5 minutes. That is pretty long. Then we start with propofol. I give 30 milligrams. Joe closes his eyes. Joe, are you asleep? He opens his eyes again. No, he's not asleep. Another 30 milligrams of propofol. We wait a little. Joe closes his eyes again. Joe, are you asleep? No reaction. We shake his shoulder. Joe, no reaction. Joe has reached the clinical endpoint of tolerance to shake and shout. We give another 40 milligrams of propofol to place the LMA. This is done by the resident in one gentle movement. We have actually good residents. Joe is not moving at all, and the NSRI is 5. We start ventilation, and we choose for sevoflurane the end-tidal target of 1.3%. We can see on our SmartPilot over here where we are and where we will go in 10 and in 15 minutes. Now, 1.3% end-tidal target is about 0.7 Mac for someone in his 40s. This may not look much, but on my visual drug display, I can see through the combined effects of sufentanil and Sevo that I'm clearly above the Mac 90 isobol. As you see over here, the effect site concentration of sufentanil is slowly going down, and also we see that the NSRI is moving up. So I could do two things. We could give more sevoflurane, but instead we choose to give another bolus of sufentanil. You may also notice that the end-tidal target of Sevo is already reached, but the effect site concentration is still only 1%. This confirms what Eager already said in the 60s. The concept of MAC is only valid after 50 minutes equilibration time. But back to Joe. The surgeon starts to close the wound.
I must ask you to come to a conclusion shortly, if possible.
Okay. The surgeon closes the wound. We turn off the SIVO, and the NSRI starts to rise very fast. The nurse removes the drapes, and Joe opens his eyes. And we can transport him to the recovery room, awake this time. This is the setup we have in Aalst. We have the ZEUS, we have syringe drivers, and we have the SmartPilot. They are all connected. Information from the syringe drivers and from the ZEUS is transferred to the SmartPilot. It's almost a miracle for a gasman like me, but the SmartPilot gave me the confidence I needed to start total intravenous anesthesia again. As you can see here, these are the drugs. You may notice we only give a certain amount of drug over time. It's like TIVA, but we have effect site concentrations on the screen of the SmartPilot, and if we keep them stable, we can give a sort of TCI. What I also did is giving sufentanil in a continuous infusion. You may maybe you worry about context-sensitive half times, but through the information I got from the SmartPilot, this proved to be not an issue for infusions lasting 2, 3, 4 hours. We have a clinical example here, which I'm not able to show because of the lack of time, but we can discuss it later. If this would work well, I would already have finished. Now, the NSRI is only a calculation. It gives a prediction. It's not a measurement. It's not connected to the patient. That's why now and then we use the BIS to keep our minds easy. In 2013, there was an award-winning abstract at the ESA meeting in Barcelona from Hannivoort and colleagues from Groningen. They compared NSRI to a lot of other depth of anesthesia monitors like the BIS, and it turned out NSRI performed better. The SmartPilot has limitations. Not all categories of patients are included. Also, if you enter drugs that are not incorporated, or if you enter the wrong data, you will of course get a wrong image on your screen. Always keep in mind that it's a calculation, not a measurement. There's inter-individual variability, and the probability of no response is a prediction. But if you start working with the SmartPilot, it will convince you of the very good science behind it. I advise you, if you start, just give anesthesia the way you always do and see on the screen where you are. Most likely, you will overdose. By using depth of anesthesia monitors, by avoiding neuromuscular blockers when they're not really needed, you will become more confident and you will be able to fine-tune your anesthesia a lot. Also, the SmartPilot can be used as a GPS if you use new anesthetic techniques. Currently, we don't have a SmartPilot in every OR. They have a serious price tag, but even without it, you can use the understandings you got through working with the SmartPilot. Wait a long time, wait enough time between sufentanil and propofol. You can always use depth of anesthesia monitors to become more confident. Don't worry about sufentanil infusion in case of context-sensitive half-time, and we know that anesthesia below 1 mAc is possible. If you're interested in visual drug displays, you can always come and visit us here in Aalst, because combined drug effects are here to stay. And we hope that anesthesiologists will be interested in this technology. It's up to you if you're willing or not to upgrade your daily practice. But we believe the visual drug displays are a huge step forward. Thank you.
Thank you.